you've had training with us or someone else in the past around the neurodevelopmental aspects of trauma. The fact of the matter is, when we talk about the brain and stress, the brain explains what we see in terms of the physical, the mental, the behavioral effects of early trauma, or really trauma across the lifespan. And when we look at, there's a tremendous amount of data out on ACEs. Since the original ACE study, which I'm going to talk to you about very briefly, and I imagine most of you are familiar with, that first publication in 1998, if you go online and Google adverse childhood experiences or ACEs,
something on here.
Excuse me, we can hear someone talking.
I know that our office is not always on
hello.
Every out processing sheet. We're usually on out processing. We're not always on everybody's in processing sheet. So,
yeah.
And I actually.
Shall I stop or?
I'm going to try to put them on mute.
Are we, no, we're right there.
Okay, did that work?
I don't hear it.
Okay, great.
Are we good? Okay.
Yes, I've muted them.
A lot of ACEs presentations and all the data around it, if you would Google ACEs and online, you're going to see lists come up through the Centers for Disease Control, the CDC, and elsewhere, with over 100 publications just nationally. And if you go worldwide and bring the World Health Organization and so forth into it, it's even bigger than that. But what we're going to focus on, a piece of the research that is looking at the effects on children, because the effects start early, and that is something we feel really needs to be lifted up, in addition to understanding that there are long-term health effects associated with these exposures. And what we're going to close with today is a resource that we have partnered with a number of national organizations to develop, because our goal is universal education, and we embed assessment in that tool. Next slide, please. So again, as we start with this, we're talking about a framework of hope and resiliency in talking about adverse childhood experiences, because the fact that they are part of our past does not mean they need to be our destiny. And that's what this is all about, and what we're learning more and more about. Next. So when we talk about resiliency, it's a word that's used a lot, and what are we talking about there is positive adaptation despite adverse experiences. And when we talk about this, there's the big R of relationships, 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 healthy relationships being a key protective factor. Social and emotional learning. You will not look at an evidence-based intervention for early trauma where there's not good content, consistent content on helping kids with social emotional learning. And that is what is so great about the conversation going on in this state, Department of Education, what schools are doing in looking at evidence-based, what we call SEL curricula, social emotional learning curriculum. Every child deserves this, and kids who have had trauma, tough times in their life, the value of this is enormous. And when we look again at resiliency factors too, and these are curricula that are being implemented in schools around the country and in Alaska, mastery of school is a huge resiliency factor. But a child needs to be able to have self-regulating skills, to be able to sit in that classroom and learn. And so it brings it back to why SEL curricula are so important. Having a special skill, something that they can do, that they can shine at, is another big resiliency factor. And when you look at the resources that we're working on, and you'll see this in the Partnering with Parents handout that you have, we are continually embedding the message, it is never too late, because of the plasticity of the brain, the capacity of the brain to heal and change is huge. Next, please. So I wanted to point out this resource, which is has great information. There's a couple of books along with it. This is Ken Ginsburg's work, which is, he's a pediatrician specializing in adolescents and then specializing even more focused in resiliency. And he has developed the 7 crucial C's of resiliency. So this goes a little bit further than the previous slide, and this website is an excellent resource to check out around what we're talking about, competency or that mastery, having a special skill, building self-esteem or confidence, connection, relationships, character, contribution, when we can create positive roles for kids, especially who are weathering storms of tough times like adverse childhood experiences, coping skills. We train the military on stress management skills, and kids need it too. All kids will benefit. Again, kids with trauma, many of whom are living in a war zone themselves, need those stress management tools. So you again will see with social emotional learning, it's very skill-based to give kids age-appropriate skills for that, and control is the self-regulation, because a child has to be able to down-regulate, get the calm, to be able to learn. And we are all born with resiliency, and it's something that we know how to nurture. And using a strengths-based approach. And I'm going to close with a comment on what's happening with high capacity, in other words, trauma-informed schools, which is an area that we're doing a lot of training. There's a lot happening nationally, and communities that are becoming trauma-informed and actually able to show with population data from their behavioral risk factors, surveillance system data, and other sources, that they are reducing the prevalence of adverse childhood experiences in young adults and the positive outcomes associated with that. And Washington State, as many of you know, is an absolute leader because of their commitment to this issue. Next. So if we were going to talk about the neurodevelopmental implications of trauma, what can happen to the brain when bad stuff happens early, we're really talking about toxic stress. But all stress is not toxic. Kids need, we all experience stress. Children need to learn how to deal with stress. And so we talk about positive stress or eustress. Things happen every day. It's part of normal, healthy development to learn how to manage stress. And of course, children learn that from their adult caregivers. And a little bit of stress can make someone more alert, more aware, able to face challenges, whether it's a tough test at school, public speaking, the big playoff game. And then as we move to the right, we have tolerable stress. In reality, tough things happen for everyone. It can be an accident, an injury, loss of a loved one. And these experiences will set off the body's alarm system so that there's more stress hormones going around, getting the body ready for stress. But the thing is, 2 key aspects. It's not prolonged, outgoing. It's not hopefully occurring with a lot of other bad stuff. And there's resiliency in the support of caring adults that can help that child to understand and work through what they have to deal with. And that's what keeps that stress from going toxic. The problem is, particularly with adverse childhood experiences, that they tend to be frequent, they tend to co-occur with other stuff, they tend to be prolonged in the exposure, and with that kind of ongoing pushing the alarm button in the brain can cause changes in how the brain organizes and where kids spend their time in their brain. Too many stress hormones actually acting like an acid wash on all of those connections that kids need to be making in their brain. But in and of itself, not necessarily toxic unless we're missing the resiliency factors. The missing resiliency factors, particularly the support, nurturing of a caring adult parent who can help that child to feel safe, loved, nurtured in their environment is more important than looking at the number, per se, of bad things happening. It's the resiliency factors in a child's life that really tell us what the effects of these experiences are going to be. And the most important resiliency factor is that parental support. Next, please. So I know in the past, especially as a scientist myself, when we used to talk about the mind-body connection, and particularly since I live in Homer, that it would often be considered by others as a woo-woo kind of thing. But the more we've learned about brain development, and it should surprise no one, the brain runs the body, we can really explain every physical, predictable, mind you, physical, mental, behavioral, cognitive outcome that we see with early adverse childhood experiences relative to how stress goes toxic, can affect the brain, and then what the body does to try and deal with that. There's a reason why these children get sick more often and are sick longer due to the depressed immune system, because that's what the body has to do when it's in an emergency status. And when you keep pushing that button, you get chronic inflammation, and the issues are predictable, as is the seeking behavior to try and self-medicate, getting to that allostasis, trying to feel okay. Adults do this, of course, and children are as good as well. And what can interrupt that pattern, again, are some of the resiliency factors that we already mentioned next. And I think when we used to talk about this in the past, we kind of looked at it as a black box, and that's why that box is not black, because we now understand how toxic stress works. We understand that because even when one has a gene that would predispose them to a certain health problem or behavioral risk factor, whether that gene gets expressed or not has a tremendous amount to do with the environment. So that's the epigenetic piece of it, which is so extraordinary. And when we talk about nature versus nurture, well, we drop the verses out because it's an and that is underlined like 3 times. It's both, and the environment plays a huge role in what will be the expression for disease and health overall. But we also know that without the resiliency factors, we can see disruptions in the brain architecture. So if you haven't had training on that, I strongly encourage that, and I also strongly encourage you to seek the latest training in science on adolescent brain development, because while we talk about 0 to 3 and 0 to 6, the changes occurring during adolescence are absolutely phenomenal, and if we miss them early on, we are likely to see a lot of symptoms and problems that we worry about so much in Alaska that I'll be talking about shortly emerge during adolescence. Next, please. So when I say adverse childhood experiences, what are we talking about? In the time we have today, I'm just going to focus on the original ACEs study, which looked at child abuse, the sexual, physical, psychological, childhood neglect, which is physical and emotional, and then also looked at household exposures. Growing up, an adult in the household who was mentally ill, had a substance abuse problem, domestic violence, of course, exposure to domestic violence is included, a family member who's incarcerated, loss of parent due to, in the original study, it included separation, divorce, abandonment, and that has been modified now to focus more on death and abandonment of a parent. But those are the original ACEs. Next, please. And this picture here makes a point that it's really important to understand about the ACE study, that first landmark publication in 1998 that now has 100 more publications off of it. Nevertheless, that we are the 20th state to join in now collecting our own ACE data through the behavioral risk factor surveillance system. But when you look at the numbers that I'm going to talk about around the ACE study, understand, first of all, that it's the largest study of its kind to ever look at these consequences of early adverse experiences and look at them over the lifespan. And the study population, next, is people like us. They were predominantly, as far as income, middle, upper class, majority college educated, many graduate school levels. This was Kaiser Permanente data, and Kaiser Permanente partnered with the Centers for Disease Control when the CDC saw the importance of what this data was showing and expanded it to a huge study, ongoing prospective design, which means it's a very strong type of research design that we can really hang our hats on. And they did 2 big waves of data, but Kaiser Permanente, because it's a health maintenance organization, it has all the health records for their patients' clients. So it's unusual that you can look at decades of health information. And these adults were asked about their childhood experiences and then followed forward. And health data, not just mortality data, but their hospitalization, their prescriptions, emergency room, doctor office visits, is the kind of information that could be looked at. And for nearly, it actually is now over 20,000 adults. This is unusual in the U.S. to be able to do this kind of research, especially of this magnitude. Next, please. So when they looked at the initial data, and as far as the prevalence of how common adverse childhood experiences were, it was shocking for the researchers, particularly with what we wouldn't consider an at-risk population, but more privileged, healthy, working Americans, to see how common physical abuse was, more than 1 out of 4, nearly 1 out of 4 for sexual child abuse. We look at substance abuse, having an adult in the household with substance abuse problem, again, more than 1 out of 4. Domestic violence was only looked at in terms of physical domestic violence against the mother, still more than 1 out of 10. And these numbers were a huge shock. Next slide, please. And the other piece around this that was surprising to researchers, although when we think about it, and if you're working in the field, you understand it only too well, is that ACEs, adverse childhood experiences, are good buddies. They hang out with one another, but not probably to the level, we didn't recognize the level to which this is true, that if there's one ACE present, there's an 87% chance that there's some other bad thing happening as well. And so when we look at the numbers here, a third of the study population indicated no history of those experiences, but 1 out of 4 had at least one, and we go up the scale there. Being able to count the number of ACEs and then look at that against the health data created a very unusual opportunity to look at something that epidemiologically we call dose-response relationship. And that's, if you're an epidemiologist and you can do that, you are famous forever. It's a very powerful tool and can infer causality when we look at this data. So it was quite extraordinary. Next. Now this next slide, I just wanted to show you in the adult data on adverse childhood experiences in Alaska is being analyzed by the state of Alaska, Department of Health and Social Services right now. So we'll be hearing about that data very soon. But this is data that we have about Alaskans, children from up to the age of under 18 years of age, coming from a national survey that's being done, the National Survey of Children's Health. But it's important to note for this telephone survey with households that they did not ask about child abuse or neglect, although it did include childhood exposure to violence, and that has to do with issues that would occur with having to report, and stop the survey and so forth, unreportable issues. So, but what we see here for ACEs, again, not including child abuse or neglect, although they did add a question on exposure to community violence, is that 49% of children indicated there were no ACEs for that child in the household. They were actually interviewing an adult caregiver. 25% indicated one ACE, and 25% two or more ACEs, so 1 out of 4. So even excluding child abuse, and we know, unfortunately, how prevalent that is in Alaska, we see these numbers for children in Alaska. Next. So I wanted to lift up the domestic violence piece because it is a very strong predictor in the world of adverse childhood experiences. And when we know domestic violence is going on in the household, the probability of another ACE happening is even higher if the domestic violence is present. It's 95% probability. It's why comprehensive assessment, screening, is so important, particularly since we're so aware of the overlap of domestic violence and child abuse. And to break it down even a little further, that when we look again at children exposed to domestic violence, more than 1/3 had 4 or more of these things happening at the same time. And that, of course, gets us very much into the dilemma of toxic stress, several things happening at the same time and prolonged exposure. And this is the piece of ACEs research that I think we really need to be lifting up. And I'll mention, too, in case we have any physicians or others interested, the American Academy of Pediatrics will be launching an online module on ACEs and pediatrics very shortly. I think after the first of the year we should see that online. And if you need information about that, you can contact us. But when you think of some of the big ticket items in Alaska and the nation that we're really focusing on, such as childhood obesity, I can show you research, good research, population-based research showing dramatic increase in the probability of obesity, not just for adults, because that's how the ACE study started at Kaiser Permanente when they discovered that link, but also for children, particularly children under the age of 5. And we know that when that starts to occur early, how much harder it is to address and prevent obesity across the lifespan. So very strong connection there. We see a strong connection for teen pregnancy, choosing boys and girls to become pregnant as opposed to just talking about unintentional pregnancy. All the work being done around bullying in our schools and elsewhere, well, highly correlated. Dating violence, unfortunately, we are a fourth R state where our state and Department of Education is promoting and helping schools to implement primary prevention with the fourth R. And the connection between these experiences and dating violence, no surprise, is very, very strong. Fighting and carrying weapons to school, early initiation of tobacco use, so there's a big connection that we talk about with tobacco cessation programs, self-medicating in terms of early alcohol and drug use, and suicide. We do a presentation that is totally focused on ACEs and suicide because the correlation is so strong for youth and adults. Next. And relative to just what this looks like in the classroom, I wanted to, as I mentioned before, we have a very focused presentation that we do for trauma-informed schools. But this is one of the reasons that this is so important in school, because of the connection that we see between ACEs and developmental delays. That children with 3 or more adverse childhood experiences are nearly 4 times more likely to have developmental delay, because they're 32 times more likely to have behavioral problems in school. And with this data, if you look at these studies, what you would see is that dose-response relationship. Each ACE you add, more likely to see that outcome. And that is really illustrated in the next graphic slide about ACEs and suicide attempts and this is true for youth and this is true for adults, that with each ACE you add, you dramatically increase the risk of suicide attempts. And it is also true, next please, for self-medicating. And the pattern we see with that is very important for thinking about what prevention looks like. We see that teens exposed to ACEs are more likely to start drinking early. Often what I've seen in my work is the first time they had a cold or a cough and they have cough medicine when they're 7 or 8, whatever it is, and they feel a little bit better. They like themselves a little bit better that day. So when things get really bad or scary again, where's the cough syrup? And when the cough syrup's gone, then what else is in the household? Household products, topping off the bottles, and so forth. But while we know, I do a lot of work around adolescent brain development, and we have that whole piece, of course, emerging during adolescence with experimentation and so forth, peer pressure around drinking. But what we know for teens with ACEs is that the reasons they give for trying alcohol and starting drinking are different, because they will tell us that they are drinking to cope during that first year. Next, please. Mentioned the dating violence connection, and I just wanted to show you how strong the data for ACEs and the connection to perpetration and victimization and dating violence is, because with this type of data, you're able to calculate a statistic called an attributable risk fraction, which is another highfalutin statistical technique that it's quite powerful. And so then you can predict associations. And so this is with a nationally representative sample, point being very strong and accounting for about half of what we see with dating violence. And of course, if violence is a norm in the household, and teens will tell us they're looking, for someone to love them. That's the connection for teen pregnancy. But unfortunately, they don't know what healthy relationships look like. Next. And because of all that's been talked about during these webinar series around domestic violence and prevention, I just wanted to share the statistics here around how adverse childhood experiences are associated with then predicting not just dating violence, but the risk of domestic violence. And this is why with our governor's initiative around domestic violence, I stress that adverse childhood experiences must be looked at and considered as both a risk factor and what we can then look at relative to prevention and protective factors around this, because it is so strongly correlated with domestic violence as children with these experiences go into adulthood. It's a prevention moment in a huge way. And the pyramid next that is so famous from the Centers for Disease Control around ACEs, that's what it's all about. We know that these early experiences can disrupt early brain development in ways that can impair social and emotional and cognitive skills. So, big star here for what can we do, social emotional learning curricula not only helps kids do better in school, academically achieve, which is no surprise because they're able to be able to self-regulate, to be able to focus and learn, and teachers can spend their time teaching as opposed to trying to manage all the behavioral problems that this can look like: impulsive, reactive, hypervigilance, hyperstartle. Got to get you before you get me, because that's some of the brain piece of this, of how the brain can work when it's more focused on survival. And that next piece in the pyramid can unfortunately be adapting health risk behaviors, unhealthy coping behaviors. And That is why these exposures are so predictive of self-medicating, substance abuse, and so forth. And it's associated with a lot of health problems for kids and adults. But we know that the more we can do to grow resiliency, the more we can become trauma-informed in schools, communities, and parenting. This is how we can topple or turn over the pyramid. Next, please. So the focus for the second part of this webinar, and very much where we've been working, is we see a tremendous opportunity in trauma-informed parenting. And so what I'm going to be segueing into now is talking about a resource that we've developed with several national partners to work on this. We know that effective parenting skills and parental warmth can, that kind of promoting resiliency among kids to domestic violence leads to dramatically improved outcomes. In fact, it has been shown to prevent asthma, which is a common health consequence for kids exposed to domestic violence. So we're talking, this isn't touchy-feeling, we're talking about preventing physical disease. We're talking about epigenetics here, about how important this is as a protective factor to buffer the effects of stress, to keep it from going toxic. Next. And where this kind of landed us is the importance of universal education, to meet parents where they are at and realize that they, especially because of the trauma they experienced as children, may not, and at a time when no one could or would talk about this, may not know how this can affect their parenting skills, their children. And by using a trauma-informed parenting approach, we can help them to understand their own lives and help them to make healthier choices to protect their children. What's happened with the ACE study that's so phenomenal is it has shifted the thinking from particularly for survivors from what's wrong with me to it's about understanding what happened to me. And that is the empowerment and prevention piece around ACEs. What that means at Kaiser Permanente, when their physicians started asking their patients, how do you think, because they screen routinely for adverse childhood experiences, and ask, how do you think this has affected your life? And in that alone, being able to make that connection, have that conversation, dramatically reducing physician visits over the next year as people began to understand how this could be connected to the health issues that they were struggling with. Next. So you have hopefully received and printed, and if not, we can get it to you afterwards, a PDF handout that is for the Partnering with Parents resource. And it's called Apps for Raising Happy, Healthy Children. And if you're looking at the handout and you haven't seen the hard copy of this, you'll realize, you may not realize actually, that this is a little booklet. And it's the 5th in the Amazing Brain series, which is a free resource through the State of Alaska Family Violence Prevention Project. And I've put Joe Gottschalk's phone number and email up there. She runs our clearinghouse, so you can order copies of this. And our whole mission is to get this information in a user-friendly, non-stigmatizing wording resource. They're written at the 5th grade reading level. Some of them have been translated into Spanish, and we'll be following up to find out more about that. It's another agency that's doing that. This one is designed to look like an app, because what we're hearing more and more, especially from young parents, is that they want to be able to scan it, like a QR code, and I'll point one out in one of the sample pages. There's actually a link to a specific app for deep breathing exercise, which I definitely have on my smartphone. But it's about providing tools for parents in a positive, supportive way, and we've embedded what we call universal education with self-assessment. So there are questions about ACEs in this resource, because that is how ACE assessment, even in the healthcare setting, like Kaiser Permanente, has predominantly been done, that the person looks at the questions and answers them themselves, and then has the opportunity to talk to their healthcare provider or whoever. For example, the state of Maine has integrated assessment for ACEs along with questions for resiliency into all of their Head Start programs, which we think is fantastic. And part of this educational tool is also those practical strategies for parents. So I'm just going to take you to the first page. I hope this isn't too small for you to see, but you can see that we're very much using a positive approach to talk to parents about the fact that we know parents want to do the best they can, but the fact is that sometimes things that happen in our past that we may not even recognize, they can hopefully help us to be stronger, but sometimes can make it harder for parents to be the kind of parents that they want to be. So we tell them that this is a resource that's got standard phone numbers and websites, but also cell phone apps and information that they can scan right in, and that it isn't just for parents, but anyone really who is a caregiver or who cares about children. And I'm not going to take you through every page of the booklet, which you would have in the PDF handout or when you request samples. But the first 2 pages are very much about meeting parents where they are at relative to their life experiences, acknowledging that parenting, even on the best of days, it's hard work, and there's challenges and disappointing moments. And so right up front, we're connecting them to parenting hotlines where they can call for information on parenting, which would be the page across from this. But I'm going to jump ahead for time's sake to show you that after we start with this conversation with parents, we have 2 pages. Can we go back to the purple, please? Thank you. We have learned that it's really important to make these resources colorful and graphic. So each section has a color to it. So the purple section is talking about stress, and the other side of this page really talks about that slide that you saw, looking at different levels of stress, but we don't talk about toxic stress, because that is a word that when we piloted and pre-tested was a scary word for parents to hear. Instead, we talk about the fact that all stress is not bad, but that when there's tough times at home, that can lead to levels of stress that are really hard for kids and for parents, and can be unhealthy. And that leads us to the page that you see, just still on purple, to talk about some of the effects that parents are likely to see that can be associated with when a child becomes overstressed, both behaviorally in terms of acting out, becoming more aggressive. There is a reason. Look at the data for the state of California, where we're seeing 1 out of 4 children being basically expelled, permanently excluded from publicly funded early childhood programs due to their aggressive behaviors, predominantly aggressive behaviors, those kids who need that support most. And it's leading to the development of special early education programs, because it's critical for lots of kids, and especially for these children. But we can predict the problems that we're going to see physically and behaviorally, as well as some of the mental health issues. Next, please. So now we're into the blue section, and where we have 2 pages dedicated to just talking to parents about how stress can affect their parenting, letting them know if they had these experiences as children, it's not their fault. The critical message that we know about domestic violence is the same for ACEs. They cannot hear that enough because they blame themselves for what happened when they were children. They don't make the connection to behaviors that they may be trying to change now, or things that they do that just don't make sense. And the critical piece is creating a toolkit that gives parents some simple strategies for reducing stress. And here you see, and they occurred on previous pages too, but we have those QR codes, those boxes on the right there, so that you can take your smartphone and go right to that tactical breather training app. Because you know, if you've dealt with any of this yourself, when you are in the moment, when you are being overwhelmed with stress, and maybe trying to make that decision not to use physical or corporal punishment, which unfortunately is so much more likely when a parent has had these childhood experiences. In that moment, trying to remember how to do deep breathing, for example, that's totally in your cortex, and that's not where you're at in your brain. But if you can go to a visual, an audio stimulus, such as an app, and that's how this tactical breather works on your cell phone, and you can see it, you can hear it, that will be able to access an area of your brain when you are in overwhelmed with stress and red alert, and be able to walk through that. So part of that toolkit, and just talking to parents about, taking a few minutes, stepping back, being able to talk to other parents. Next, please. We have 2 pages where we then get into, we don't start in the beginning of this asking questions about which one of these things happened to you. We start with that conversation around trauma-informed parenting, and then go into the assessment piece. And this page is dedicated to just talking about the fact of physical and child abuse and neglect and exposure to domestic violence, and some very specific resources on this, because in the world of ACE exposures, these are heavy hitters, so to speak. So we wanted to have resources, information up front and center around these. And then, next please, the next page, it looks different in your book, but I just wanted to, I pulled out the questions as opposed to showing you the page of the booklet here, to make a few points about the questions asked in this booklet. We asked some of the standard ACE questions around household, an adult with having a mental health problem or suicidal. I have in parentheses there the source of that exposure, because some of them are specific to the original ACE study, but we've added some based on the work of the World Health Organization, for example, which is at WHO, after some questions. We asked, of course, about a parent who's been in jail or incarcerated. And by the way, we just worked at the pretrial facility in Palmer when we piloted this booklet in a training with their parenting program. And now it is being offered to the Department of Correction trainers statewide who we work with. And they do amazing work. And I learned a lot from the men that I had the privilege to talk to and work with about this. As one of them said at the very beginning, we are the byproduct of ACEs. It's not an excuse for behavior, but for understanding what we don't want for our children. Then you'll see some of the other standard ACE questions as we go down about, loss of a parent or guardian, being a witness to community violence. Philadelphia is there because of the work that they're doing on an urban ACEs project, bringing new questions in. Of course, we ask about bullying now. When the ACE study started, we didn't know what we know now about bullying. So that has been added, as well as prejudice, discrimination questions about that. I think in Alaska, we'd very much like to add a question around, forced to attend residential schools is something that has come up in talking about what ACE questions should look like for Alaska Natives and rural communities. Discipline, we know too much now about the impact of physical and corporal punishment and how likely it is to be occurring even more so with these experiences. So we have 2 questions on that. And when you would look at the booklet, what you would see is we ask those questions for the parent and then their child, and then encourage them to talk to their healthcare provider, someone they talk to, trust about these experiences. And where we end with this is building blocks for resiliency. I just see a comment here about not able to download any attachments, so let me just mention something right now. After the webinar, in addition to getting them from this webinar or ordering them from Joe, you can go to www.instituteforsafefamilies.org, and so that's instituteforsafefamilies.org, and under materials, which is one of the headings on their webpage, you'll see all the PDFs for the Amazing Brain series, including this one, Partnering for Parents. Where we end with this booklet is a little bit, where we started. It's the resiliency sandwich. We talk about building blocks for resiliency and the fact that we're not just talking about it for kids. This is a package deal. If, again, meeting parents where they're at. If a parent, because of their childhood experiences, didn't learn how to self-regulate, which is one of the key resiliency skills to help kids in the classroom, to help kids deal with these experiences, how will their children be able to self-regulate? So we have to, again, support the parents and the child. It's a package deal in terms of outcomes. So we ask about protective factors that they may have experienced as kids. We incorporate content on resiliency throughout, and this whole section that we're talking about. Next, please. And I'll probably just look at this one, very quickly. But I wanted you to see here that we don't just ask about the bad things that could have happened to parents and their children. We also ask some questions about resiliency or positive experiences that parent may have had to help them see what can also, how it may have helped them, and think then about how it could help their children. So that's what this page is about. I'm a firm believer that if you are going to implement routine assessment for ACEs, as is happening in so many healthcare and other service settings across the country, you need to include questions on resiliency. So that's what you see in this section here. And what we focus on in this booklet, because as you saw with the 7 C's, and there are more than that, there are many resiliency factors. But what we have learned through our work and the research is that if we had to focus on 4, it would very much be around the relationships, so those connections, the self-regulation, as I've alluded to in the very beginning, that self-esteem and confidence and empathy skills. So there are the final pages of this free parents resource focus on those 4 resiliency factors, and so I've pulled out one here in particular with the first one, which is about healthy relationships. And the way each of these is structured is whenever there's a resource, a QR code, a website we can steer that parent or caregiver to, we have that QR code. And we are, giving an explanation of what we mean by healthy relationships, because the thing that I learned working in domestic violence is we have a lot of adults, because of the experiences they have had as children, they don't know what a healthy relationship looks like, and neither will their children unless we have this conversation. But then we give specific examples kind of situations that you did a good job being quiet like I asked you to, good listening, how to, the kind of words of how we know how important it is for these children that often do not hear, I love you, that parents assume that child knows that, and how important it is to actually be saying that. I mean, there's lots of research on that. It seems obvious, but it's something that we have to reinforce and say again and again. And then talking to that parent about themselves, about taking time out for themselves for healthy relationships, to be able to have that social support, because that is a huge protective factor in the world of domestic violence, in the world of adverse childhood experiences, if we want to be talking about prevention. So that is how this is structured, and you would then see pages for the other, for self-regulatory skills, empathy, and such that we are emphasizing. Where I want to wrap up here now, I am in my final moments. Next slide is just what I mentioned about high-capacity communities, is the work being done down in Washington, where public health and communities create a safety network like you'll see in Walla Walla. Walla Walla rocks. And we need to create, and we are seeing in communities in Alaska where we will have our own Walla Wallas, collaborative leadership, community education on ACEs, and the innovations around it, which I've only just mentioned one tiny piece today. Looking at system-based strategies of, entities working together. And I just can't emphasize how important the trauma-informed school piece is to this, and how excited I am for, what we're seeing in, Alaska's leadership around this. And realizing that we learn as we go, so it has to be outcome-based decision-making that is flexible. Next, please. And so you put this together, and what is happening in Washington State is with this higher community capacity, excuse me, they are seeing a lowering of ACE scores over the 10-year period and forward that they have now been tracking ACEs in their with population-based data, which again, as I mentioned, Alaska will have its first year of data, has its first year of data this year that's being analyzed. Increasing social and emotional support, and actually being able to show lower rates of mental, behavioral, and physical health problems in young adults. This is huge, and this is the goal. I mean, we're talking about tangible outcomes. Last slide, please. And so this is, that slide was just alluding to the changes, or noting the changes that are being seen in the Washington. And I think the big question here, as efforts are going statewide to provide training on ACEs through the Alaska Children's Trust and others, is what can this look like in my, in our communities? I'm very fortunate to be based in, Homer, where we have the Homer Prevention Project and the MAP project, an incredible collaborative effort to bring our community together around ACEs, and our schools are involved and everything else. So I just want to open, I know people are going to have to fill in, I want to open to questions.
Yeah, is there anyone, I didn't see any questions typed in, except one person asked if you could explain epigenetics a little bit more. But if folks have questions and they want to either unmute their phones and ask them, or type them in, feel free to do so, and we can answer some questions in the last minute or two here.
Thank you, and sorry I didn't stop a little bit earlier. The epigenetics, I'm probably not going to do it justice, but we used to talk about genetics, and basically you got this gene, and it's kind of predetermined then that gene is going to express itself, and you're going to have that disease, or that issue, whatever is associated with that gene. And what we've learned with epigenetics, and I'll just use schizophrenia as an example, take identical twins So same genetic, makeup, and let's say late adolescence when schizophrenia often expresses itself, that one of those twins does develop schizophrenia. What is the statistical probability that the other twin will? Generally, people will agree around 50%, depending on whose research you're looking at. No two brains are identical because no two persons' experiences and environment will be exactly identical. And epigenetics is the role of environment in determining, shaping whether that gene gets expressed or not. And that is the power and the potential for prevention, ultimately, that we can create nurturing environments, and social support that actually the things that we do, the little things that we do can prevent the expression of a disease or promote a gene expression that is a resiliency strength factor as well.
Thanks. And I know some people have to sign off, so I want to thank them for joining. I did see two other questions if you have a minute here, Linda. There was one question about whether there will be this information received in rural Alaska around the ACEs study.
Yep. I think that it's going to be about how we present it, and I think that's why we have to lead with resiliency, looking at what resiliency communities and people have, acknowledging that what adverse childhood experiences may look like in different cultures are different. So being open to that. But I think it's the dialogue, and I think if we approach it in the fact that this is not destiny, that it's preventable, and that we're learning more and more about what we can do about it, I think it will be a dialogue that we can all learn from and grow from.
Great. And then there were two other questions that were related to schools, which I'm not sure you can answer, because one was about what the Department of Education, where they're at with working with trauma-informed schools in Alaska, and then a curriculum. Okay.
Well, for curriculum, just because people are signing off, I would be talking to Patty Owen with the Department of Education around the social-emotional learning curriculum that they're looking at. We also have evaluated a number of evidence-based, looked at and reviewed evidence-based school-based curriculums such as CBITS, which stands for Cognitive Behavioral School-Based Program, and so we can provide a profile of that. It's a 10-week intervention. There's great evidence-based tools out there. They don't cost $1 million. They don't take a year of time and so forth. So yes, we can share that information.
Great. So maybe we can share more information. And did I miss a question? Someone asked if there were websites for children's activities.
For children's activities, the first website I'd mention right now, and definitely can contact me for more, is to go to www.promisingfutureswithoutviolence.org for really great information around kids exposed to violence and fact sheets and tools around that. And I can share some more as well that aren't currently posted on that website.
Great. And what was the name of the curriculum again?
Oh, CBITS. It's C as in cat, B as in boy, I as in interactive, T as in training, S as in Sam. And I'm blanking. It stands for cognitive behavioral. If you Google CBITS, it's going to come up. We have the manual, but it's an evidence-based 10-week school-based intervention for kids who have experienced trauma. Email me at linda.chamberlain@alaska.gov, and I'll send you a review of the program. Or you can go to that www.promisingfutureswithoutviolence.org, and there's a review of that program online.
Great. Well, I know folks have to go, and I really appreciate your time and sharing so much information with us, Linda.
Great. Yep, that's it, CBITS. Thank you, everyone.
Thank you.
stand by.